Hello everybody, hope you all are fine. The topic for discussion today is the development of the foregut and its anomalies part 2. So at the end of this session, the participant should be able to describe the morphogenesis of esophagus, describe the malformations of the esophagus and their diagnosis, discuss the morphogenesis of the stomach, describe the rotation of the stomach, discuss the formation of the mesenteries of the stomach, and describe the formation of the omental bursa. We start with the development of the esophagus, which develops from the proximal part of the foregut and receives its lining from the endodermal germ layer of the embryo. During fourth week, a two-pronged, fork-shaped septum of mesoderm, named as tracheoesophageal septum or esophagotracheal septum, which appears on caudal aspect of tracheoesophageal junction and produces grooves and folds. The folds unite and divide cranial most part of the foregut into a ventral part, which is named as respiratory or tracheobronchial diverticulum, and later the laryngotracheal tube, which divides into two lung buds, and a dorsal part, the esophagus. Initially, the esophagus is very short, but it elongates rapidly and acquires its relative final length by week 7th. Reason for its elongation are: number one, more growth of the cranial part of the embryo; number two, development and descent of the heart and the lungs; and number three, retroflexion of the head of the embryo. The lumen of the esophagus develops as follows. At start, the endodermal lining starts proliferating. See in the diagrams C and C1, which are longitudinal and transverse section of the developing esophagus. This proliferation leads to formation of an epithelial plug, which fills and almost obliterates the lumen. By the end of week 8, vacuolization leads to recanalization of the lumen of the esophagus, as shown in D and D1 diagram. Now see the D2 and D3 diagram that shows the formation of normal lumen. As regard the development of the musculature of the esophagus, the muscles of the upper two-thirds are derived from mesenchyme of the caudal pharyngeal arches, hence are skeletal muscles and innervated by vagus nerve. And the lower one-third of the esophagus receives musculature from splanchnic mesoderm, hence are smooth muscles, hence are innervated by splanchnic plexus derived from the neural crest cells. Esophageal malformations are divided into three broad groups. First one is malformation of the lumen in the shape of atresia and stenosis. Number two, abnormal communication between the lumen of esophagus and trachea in the shape of tracheoesophageal fistulas. And number three, abnormal length of the esophagus, which is usually short and is accompanied by diaphragm defect, seen in cases of hiatal hernias. A combination of factors is responsible for the production of these malformations, which are number one, unequal division due to deviation of tracheoesophageal septum. Number two, some pressure from the posterior aspect. Number three, recanalization failure. And number four, failure to elongate. Esophageal malformations comprise number one, esophageal atresia with distal fistula, which comprises 90% of the cases. In this variety, upper segment ends blindly, whereas the lower segment lumen is continuous with the lumen of the trachea in the shape of tracheoesophageal fistula. The newborn presents with excessive salivation, vomiting, coughing, choking, and cyanosis. Second variety of esophageal malformation is fistula only, that is tracheoesophageal fistula. This occurs because of incomplete partitioning of the esophagus and trachea in a localized area, and the newborn presents with episodic coughing, choking, and cyanosis. Third variety is esophageal atresia only, which comprises 4% of the cases. The upper and lower segments both end blindly. They may be connected by a cord. There is no fistula, and the newborn presents with excessive salivation and vomiting. Fourth variety of malformation is atresia with proximal fistula, which comprises 1% of the cases. The lower segment ends blindly, whereas the upper segment lumen is continuous with the lumen of the trachea in the shape of tracheoesophageal fistula. The newborn presents with coughing, choking, and cyanosis. The fifth variety is esophageal stenosis. This occurs because of incomplete recanalization of the esophageal lumen, and the newborn presents with partial regurgitation and dysphagia. The stenotic malformation of the esophagus is diagnosed by performing barium contrast study, in which a radiograph is taken while the patient is swallowing the barium, which shows narrowed lower part of the esophagus and dilatation of the proximal part of the esophagus. In another malformation, esophagus fails to elongate. Occasionally, stomach is pulled up through the esophageal opening in the diaphragm, and resultant is the hiatal hernia. Now we start with the morphogenesis of the stomach. Towards the end of the fourth week or early part of fifth week, a fusiform dilatation appears in the middle part of the foregut. This is primordium of the stomach. Soon it elongates, dilates, and broadens ventrodorsally. In other words, it is compressed bilaterally, so that two surfaces, right and left, and two borders, anterior and posterior, can be made out. Final shape and position of the stomach depends upon number one, differential growth of its walls, and number two, growth pattern and positional changes of the surrounding organs. The mucous membrane of the stomach is derived from the endoderm, whereas the musculature and connective tissue is derived from the surrounding splanchnic mesoderm. Hence, the stomach is innervated by splanchnic plexus of nerves. A notable aspect is that change in position of pyloric and cardiac end, which are seen because of the rotation of the stomach around its longitudinal as well as anteroposterior axes. Reason for rotation of the stomach around longitudinal axis are: number one, differential growth pattern with increased growth on the right surface than the left. Number two, development of spleen and its migration towards the left, and production of the lesser sac of the peritoneum. Because of these factors, stomach rotates about 90-degree clockwise left, so that the left side comes to lie anteriorly or it faces anteriorly and right surface faces posteriorly. Hence, the left vagus innervates the anterior and right vagus innervate the posterior aspect of the stomach. Reason for rotation around anteroposterior axis is the increased growth along the dorsal or posterior aspect or the posterior border of the stomach primordium, which enlarges too fast and forms a greater curvature, and ventral aspect remains relatively less developed and forms the lesser curvature. This whole process of rotation around the anteroposterior axis leads to shift of the caudal end of the stomach to right and upward, and cephalic end moves to the left and a bit downwards. Now, ultimately, the long axis of the stomach runs from above left to right below. Now, let us discuss the mesenteries of the stomach. Initially, developing stomach is suspended in the abdominal cavity by: number one, a very thick dorsal mesentery or mesogastrium, which attaches stomach to the dorsal body wall. And number two, a ventral mesentery or mesogastrium, which is a part of the septum transversum and attaches stomach to the anterior abdominal wall. During fifth week, in dorsal mesentery, the spleen develops and divides this dorsal mesentery into a dorsal part, the lieno-renal ligament, and a ventral part, the gastrosplenic ligament. Whereas in the ventral mesentery, liver develops and it also divides it into two parts, the anterior falciform ligament and the posterior lesser omentum and hepatoduodenal ligament. A notable and very interesting aspect of the rotation of stomach is that rotation of the stomach leads to: number one, formation of the lesser sac. Number two, it causes positional change of the spleen and pancreas, which lie between two leaves of the dorsal mesogastrium. Hence, during this process, the proximal part of dorsal mesogastrium fuses with the parietal peritoneum of the posterior abdominal wall, and this fusion results in: number one, splenic artery travels in the lieno-renal ligament, and number two, pancreas assumes a retroperitoneal position in front of aorta, superior mesenteric artery, left suprarenal gland, left kidney, and left renal vessels. Now we come on to the development of lesser sac or omental bursa. Disproportionate growth and positional changes of the stomach around longitudinal axis swings dorsal mesentery towards the left side. At the same time, isolated spaces appear in the right part of the dorsal mesentery which coalesce and form a space. Both these factors produce an intra-embryonic potential space or pouch behind the stomach which is named as lesser sac or omental bursa. With the passage of development, it expands transversely and cranially. It also expands caudally into the dorsal omentum. This omental bursa facilitates the movements of the stomach. At this stage, the lesser sac or omental bursa is related to stomach anteriorly, posterior abdominal wall posteriorly. Dorsal mesogastrium forms the left boundary, whereas on the right side it remains wide open, which is named as epiploic foramen. Below, the lesser sac continues into the greater omentum. To be continued as third part of the topic.